Namaskar. My name is Rajendra Shende, and I'm a chairman of TER Policy Center, which is not-for-profit organization, and I'm a former director at United Nations Environment Program. I'm also the coordinating lead author of IPCC report in 2007, which won the Nobel Peace Prize. I'm an IIT alumni and presently working on a number of interesting projects in this not-for-profit organization, TER Policy Center. TER is a French word which means earth, and it is also technology, education, research, and rehabilitation for environment. So it is an abbreviation of that as well. Today we are going to discuss, in presence of Dr. Joe Thomas, something which we have not heard earlier. We heard a lot of things about the science of COVID-19, science of vaccine development. We also know where it is getting administered, where people are getting vaccinated. But behind all this scenario, there is something called as vaccine ethics and vaccine politics. And it is being discussed at the highest level in the world platform. But before that, let me introduce Dr. Joe Thomas, with whom I will be dialoguing and exchanging questions and answers. He is an accomplished academic diplomat and a global leader in public health and also on social development. He has been active in a global health platform and social development scenes for more than 25 years. He had earlier worked as an executive director of intergovernmental organization of 26 governments in an organization called Partners in Population and Development. And in that capacity, as an executive director, he had an opportunity to represent that organization in United Nations General Assembly. Dr. Thomas is currently working as an associate dean in a faculty of social innovation partnerships and co-creation at MIT World Peace University in Pune. He is also overseeing establishment of 10 new schools under this faculty of social innovation. He remains as a consultant on health diplomacy and cooperation between the countries for reducing the burden of communicable diseases in Southeast Asia region. So he is the one who is absolutely appropriate speaker to talk about what is called as a vaccine ethics as well as vaccine diplomacy and politics. I just want to start by making an observation. We have been putting the vaccines in a public domain for administration, for administering them for COVID-19. But do we know that vaccines are also testing us, the human beings? And that is a big debate at present going on in WHO. The debate is, we are testing vaccines for efficacy, and vaccines are testing us for how we are utilizing them ethically and also in equitable way. There are a number of tools which are getting generated as the discussions go along. One of them is ACT, COVAX, which are all the products of deliberations at WHO platform for making sure that the vaccines get distributed equally. And they are not only tested for its efficacy, but also in terms of its cost. Are they affordable? And affordable to whom? Rich or poor? And also, what is the cost of storage and what kind of storages are required? And finally, of today's subject, what has been a sequence of their delivery? Who is getting it first? And who is left behind? So, vaccine equity is not just a moral imperative for discussion, but it is one of the important factors for ending this pandemic and making sure that the 2020 situation doesn't come again. And based on today's scenario, we feel that probably we are too optimistic about it. But yes, when I dialogue with Dr. Joe Thompson, we will get more of it. International cooperation for the fair and equitable distribution of vaccines, in fact, has started. I don't know whether that has been achieved or not. Today, we have seen that 413 million doses had been produced of vaccines as of early March. China produced the maximum, more than 140 million out of this 413 million. Next is USA, which produced about 100 million. And together with Germany and Belgium, they produced 70 million. And India has produced just about 42 million doses of vaccine. Now, one can say there is already inequity in production, the geographical inequity. But that geographical inequity is transferring into something extremely serious issue, which is whether we are really on the path to end the pandemic. Because as Bill Gates has said, nothing is safe unless everybody is safe. And everybody means about 7.8 billion people on this earth. And we are far away from this. So my first question to Dr. Joe Thomas, therefore, is yes, we are giving a priority to nurses, health workers, right from doctors to the shop floor cleanliness, checking people, and based on what is called as a, after the health workers, who comes and who are there in the line. And we hear about the aged people, probably next in the line. We never hear about the armed forces. But yes, from today onwards, I think from yesterday onwards, 45 years of age, above that, people will be getting vaccinated. But Dr. Thomas, do you think this prioritization addresses the ethics issue? What about disabled people? Do we give a priority to the health workers more or disabled persons more? And within the health authorities or health workers, should we give a priority within that to ladies?
international agencies are trying to deal with the issue of distribution of vaccine. And also there are many studies are coming up on the impact of COVID pandemic. And also there are different criteria are being used to look at our mitigation effects. There are many governments spending billions of dollars. United States government almost spending $1 trillion as a COVID pandemic mitigation. But all this, we can look at from an epidemiological point of view. We can look at from a political point of view. But I would say that one of the major factors to review, to analyze, to assess all the COVID-related interventions, COVID response, including the vaccine response, should be in a very strong and ethical framework. That ethics derives from one particular principle, that leaving no one behind. So this is that principle also derives from the UN Sustainable Development Goal. And again, we unpack it a little further. We are looking at all these interventions, our strategies, our efforts should be guided by the concept of health equity. Whether our interventions are contributing towards equity or it's adding to inequity. So this should be one of the basic criteria we should apply to look at major part of the COVID response. If we apply that principle to look at vaccine access, whether vaccine is contributing towards health equity or it is contributing towards inequity. So that's the basic principle. If you use that principle, the decision of who gets when and who gets what, who prioritize, it also should be based on this principle of equity. And maybe for the time being, maybe the doctors, healthcare providers must have been given access on a priority basis. But on a midterm basis and long-term basis, we have to constantly evaluate our vaccine policies, to what extent it is contributing towards health inequity. Do we have resources to sustain, to ensure that we are leaving no one behind in terms of accessing the COVID vaccine? So if you apply that principle again, if you apply on a global level, we know that the vaccine, what you mentioned about 400 million doses, it's for the time being, it's reached only to about 60 countries. We are talking about more than 100 countries, they haven't even seen the first dose of vaccine. So this is a global inequity and global ethical issue of political decision making. And it comes up the United Nations role in ensuring global equity, global justice in the broader context. So this is one part of it. Second part of it, we don't know how much money the governments, any government can put for subsidizing vaccines. So one of the danger is that now we have a very strong impetus for providing vaccine for everybody. But can we sustain it? For example, if we take the case of India, we haven't crossed more than 5% of the total population. Do we have the resources or political will to ensure that out of 1.5 billion, at least half of the population could be vaccinated? So this will remain as one of the major ethical challenge for the country like India. And also remember, we are a global citizen. And we are contributing towards, we are contributing vaccine to other countries' health and well-being. We already contributed about 40 to 60 countries' health and well-being. We are ensuring by providing vaccine, including Bangladesh and Caribbean countries. And the Caribbean countries, their main first dose of vaccine came from India through a special chartered flight. And the different leaders are speaking about India's diplomacy and generosity. So this is tremendously contributed towards India's soft diplomatic skills. So this is again, it's contribute towards India's principal global diplomacy. And the principle is contributing towards global health inequity, contributing to deal with the issue of vaccine inequity. So that's one of the very commendable initiative India did. And many countries, they didn't do this extent of what we're doing. And also India is a partner to Quad countries. There are 4 countries together. They formed a consortium to supply vaccine. That's Japan, Australia, United States, and India. These 4 countries, they created a consortium to ensure that vaccines are distributed. In that partnership, India is manufacturing vaccine. When you talk about vaccine manufacturing, what are the ethical issues involved in this? Right now, only 3 companies are manufacturing or trying to manufacture. But remember, India is the pharmacy of the world. We have the capacity to manufacture by probably about 40, 50 companies have got the capacity to manufacture vaccine. Should we allow an exemption from World Trade Organization rules and regulation or the global agreement in trade and tariff and give an exemption, allow them to manufacture vaccine? Even a country like Bangladesh, they have the capacity to manufacture vaccine. Should we allow the global community, World Trade Organization, should allow them in the context of a principle and ethics, allow pharmaceutical companies to manufacture vaccine? Because to ensure the vaccine access, we have to double up, triple up our manufacturing capacity. So I'm suggesting that we should apply the concept of ethics in manufacturing vaccine, in distribution of vaccine, in selecting the prioritization, and
So
the resource allocation.
That brings me to the basic situation which appears to be totally unequal, is that very few countries are producing the vaccines. So in short, about 10 or 13 countries are anywhere near producing the vaccines. And the others are just waiting for the vaccines to be out. Now, won't there be a situation that those who pay for that vaccines early, they will be getting that vaccine, and those who have produced it will of course get it before selling it, and those who don't have money probably remain behind. So all our objective of leaving no one behind is getting defeated. So what do you say on such situation?
I would again say that we should apply the principle of equity, health equity and health justice, even looking at the trade agreements on the vaccine manufacturing. We have to remember that vaccines are created with public money and very few limited private investment went into the vaccine manufacturing. It is subsidized. The advance check is paid by the United States taxpayers. That's why the huge production of the vaccine is, the research has took place. So this is the one factor you have to remember. And the second factor, what is the actual cost of vaccine is negotiated between the government, and it's a trade secret. So we don't have public access to find out what was the level of procurement prices paid by the government to the pharmaceutical companies. So this is, I would say that this is against any principles of fair trade. Fair trade means you should have you should know what is the cost of it, how much you're paying for it, and what's the real market value. And the third thing I would say that today the vaccine is not in the market. Vaccine is controlled supply. So this continues. And to what extent, when are we going to say that the vaccine, the patent is open, anybody can manufacture it? If you apply the principles of equity, if you apply the principle of ethics, international community is dealing with one of the biggest catastrophe in their human history, the human memory. I mean, the living memory of many of us. So can we allow few companies to monopolize and continue to monopolize the production of vaccine? This question has to be addressed soon by the political leaders of many of the developing countries.
I agree on that. I agree on that, Dr. Thomas. But the situation is, I think your observation is right, that the vaccines are not yet in the market. So the market forces are not controlling their prices, which is obvious. But what is happening today is, even a regulated scenario, certain governments seems to be hoarding it or wasting it or using it for their people in more unequal way as compared to certain countries in Africa. I mean, the typical sentence which WHO seems to be making is that only 10 countries have 75% of the vaccines in the world, and about 130 countries are yet to start vaccination at all. It has not even reached to the human beings on those countries. So looks like a pretty bad scenario as far as ethics is concerned. And we all are cherishing one particular instance, which is that in a less than 1 year or little more than 1 year, we have a vaccine, which is the first time in a human history. Otherwise, it takes about 10 to 15 years to really get that vaccine in more effective way. But having got that achievement, which is a great flagship kind of a program that happened, but still the countries are those who have muscle power, or those who are producers seems to have it, and about 130 countries don't seem to have it.
Yeah, you rightly highlighted the magnitude of the ethical crisis, the magnitude of the ethical concern we are facing. We are facing, I would say that we are an epidemic of unethical global agreements. So it is just glaring, I mean, right on our face. So this is one part of it. Second, you mentioned about the possibility of vaccine being wasted. United States government rightly, they decided to vaccinate all their population by within next year, probably 2022, end of 2022, they may have almost 100% vaccination. But if you look at the way they're hoarding the vaccines, probably several million doses of vaccine will be wasted, because you have to remember vaccine storage has certain issue. It's a shelf life, there is a very specific shelf life, very short shelf life. And also storaging in many of the vaccine, there are technicalities. So probably in some countries, they may be spoiling, they may be wasting, they may be throwing away, the vaccines which are beyond their expiry date. So this is a real situation we are talking about. At the same time, maybe for the next 4 or 5 years, some of the countries, they may not even see the first dose of vaccine. So this way, we are facing a moral catastrophe, an ethical catastrophe. We should not look at this morality on purely on a religious ground or religious domain. This has got a very specific survival issue. Who gets vaccine is also linked with who is going to survive. So it's basically we are looking at the issue of human right. It's not just ethics alone. So global community is witnessing a massive human right violation. We see that the global human rights reports coming up, and quite often looking at, whichever country is preparing the report, they have an opportunity to beat up other countries. If you look at the human right and vaccine access, it's going the other way around. But our thinking about applying the concept of ethics, concept of human rights in the context of access to ethics, access to vaccine, this we have to look at, we have to create a global dialogue. This is not a national dialogue anymore. This is a global dialogue. Probably that's opportunity we have, that's a responsibility we have. We have to take up the ethics and inequity of access to vaccine and its consequence on human well-being and its consequence on death and disability of the population. You also mentioned about how about disabled population. We are talking almost 5 to 10% of the population got mental health issues, because people experiencing mental health has got a propensity or the probability of getting COVID infection will be more among them, because of the cognitive ability to protect themselves is compromised. And just giving you one particular vulnerable population, I can come out with a series of population groups are being left out because we are forcefully implementing the criteria based on ethics, based on rights, basically on morality, political morality. It's not a religious morality I'm talking about. So we need to look at COVID pandemic from a very strong framework. It seems Dr. Chandrakant Pandau wanted to say something. Sir, you have to unmute yourself, then you have to speak.
Can you hear me?
Yes.
Yes.
Yeah.
Yes, Dr. Pandau, welcome.
Thank you so much. आप सबको मैं धन्यवाद देना चाहता हूँ for giving me an opportunity to be part of this संवाद. The first realization is I remember one of the World Health Day theme which we are going to celebrate on the 7th April. Once upon a time, there was a theme by the name Think Globally, Act Locally. But what Corona has taught us is think globally and also act globally. Vasudeva Kutumbakam. I have tremendous pride in my rich Indian cultural heritage. Vasudeva Kutumbakam, the world is family for us. That's part of our ancient cultural heritage that we have, number one. Number two, I will listen very carefully to the dialogue between the two of you, the two giants in their respective fields. I just have one dilemma in my mind amongst many dilemmas. On one hand, you want to increase the coverage of vaccine coverage. On the other hand, you put age restrictions. I'm not able to understand this paradoxical position. People who are less than 45 years cannot get the vaccine. So I don't know how to solve this particular dilemma. Dr. Shende, Dr. Joe Thomas, can you help me to understand this, please? Thank you.
Thank you.
I would like to say something. Before Dr. Thomas can intervene then, but I read the paper. That was pretty shocking. And it is quite akin to what Dr. Chandrakant Pandav is saying. That paper said that in fact the old age people, their life is very limited now, active life. So they are not contributing to the society as much as young people are or will be till they get old. So shouldn't we prioritize the young people rather than old people? Because what is the point in keeping the old people? Because their lifespan is now very limited. So that was quite a revolutionary statement which was made, and that has now made WHO to think about. And there's a good news yesterday that they are thinking about international protocol on pandemic to give the guidance to it, because there are various, various aspects and various roads which now are going in various direction. Thomas.
My take on this issue is slightly different. And probably, I again apply the principle of equity and justice in access to COVID vaccine. That should be one of the principles. If you apply that principle, why older people are left out of access to vaccine? It is a policy decision. We have the capacity to manufacture vaccines. We can double up 100 times. We have the capacity to manufacture. And why we are not manufacturing? Because of certain trade agreements. Because we are adhering to certain global trade agreements signed with the WTO. Maybe we should have the political will to break the WTO agreement and say that the countries should be allowed to manufacture vaccines to meet their immediate demand. Then we don't have to allow the older people to die needlessly. Then we don't have to allow the older people to not to contribute to society. We have the know-how, we have the technical capacity. What is stopping us is only the trade agreement and trade policies. I would challenge the justice and equity of that.
Actually, the son of a colleague of mine, ex-colleague of mine, is arriving on Sunday from US. So that gentleman has got full information about all the procedures and all that. And to my knowledge, only the certificate, etc., is essential. Certificate that he is corona positive, negative, that is essential. And apart from that, currently there are no issues about that.
My concern is about the capacity to manufacture. I'm talking about the trade agreements which is preventing us from manufacturing. Suppose, in India, probably about 20 companies has got the capacity to manufacture. But right now, Cadillac is trying with it, and Dr. Reddy's lab is trying. But the leader is, of course, from our neighbor, our Serum Institute. But why we are not allowing other companies to manufacture? That question needs to be addressed. That question needs to be identified and put it on the political spectrum, not only for India. Even a country like Bangladesh, they have the production capacity to vaccine. Why not allow them to manufacture? This is my question. That question comes from the the ethical framework.
Yeah, Dr. Panda wanted to say something. Yes, go ahead.
I'm still waiting for my question. I'm groping in dark. On one hand, you want to increase the vaccination coverage. Other hand, you put an age limit. Why don't you make it more than 18 years and increase the vaccination coverage? Why have this age limit at all if you want to increase the vaccine coverage? I'm still looking for that answer. Thank you.
Sir, my
Dr.
answer is
Thomas, yeah.
my answer is one sentence. We are talking about we're requesting for the universal access to vaccines. We are talking about universal access to healthcare, universal access to primary care, access to vaccination could be universal. That should be a political decision. I mean, we have the technical capacity to do that. We have the resources to do that.
Thank you so much. I got the answer. We're speaking the same language.
Okay.
We're speaking the same language, but in different.
Yes. So let me take this debate to another angle, which may be mix of politics and ethics. Recently, our Prime Minister Modi delivered about 200,000 vaccines for UN peacekeepers. And at that time, he said that they are also the front workers. They may not be actually health workers, but they are the front workers who take care of keeping the peace in the world so that all of us, and particularly the governments, can focus on fighting with COVID-19 and not to divert their resources for fighting with each other. So why other countries did not come up in saying that, okay, India need not provide all the vaccines because 200,000 vaccines doses are good enough for giving to all peacekeeping forces even a second dose. So at that point of time, why WHO or United Nations said that, no, not only India should not be the only country giving that vaccine. It should be equally distributed to give it to UN peacekeepers. Because now the people are criticizing Prime Minister Modi, saying that we have not yet controlled our COVID-19. Why we are worried about the UN peacekeepers? Dr. Thomas.
I would derive that issue based on the global ethics. I would say that India's decision to contribute towards global vaccine equity was a very plus point in the global level, because India is also a responsible global citizen. So we demonstrated our generosity to our colleagues, our friends, our neighbors. And at the same time, we have to look at other ways, different technology, different policy initiative to expand our own access. And we have a way out. And what we call it as in the WTO compulsory licensing. Compulsory licensing is it's a techniques within the World Trade Agreement that when there is a pandemic, when there is a medical emergency, a pandemic, government could allow to break the patent rights and allow the companies to manufacture. And I'm trying to understand why India is hesitant to provide the compulsory licensing to whichever manufacturing country, whichever company who can manufacture vaccines. And it should not be delayed at all, because India has done this for the case of some of the cancer medication. We have the experience. India has done this. India utilized this tool for ensuring access to medicines for the cancer patient. So we should not delay. We should not delay anymore. We should delay anymore from declaring a compulsory licensing regime for ensuring the manufacturing of the vaccine rapidly to ensure universal access to vaccine.
Okay, so we have now limited time because we decided that it will not go more than 30 to 40 minutes. But I have two questions, and then I have opened for other questions from the audience. One question is about ethics of research. When vaccines are getting developed, they have to be tried on human beings. So who were their human beings? Did they come as a healthy people offered themselves as a volunteers to test vaccine? Or those were the poor people who rushed there either because they are paid or they thought that they will get benefited if the vaccine is effective? So do you have, as a as a health diplomat, do you have access to the information? Who are these volunteers in India, in China, in USA, and all other places where the vaccine is getting developed?
This vaccine clinical trial got certain standard protocols, and that is universally accepted, globally accepted. When you look at the first, the cohort of the vaccine trial participants, and particularly two vaccine from Moderna vaccine and also Pfizer vaccine, that trial participants exclusively came from United States. So this is the first part of it. But whereas when the Johnson & Johnson vaccine came, they did the clinical trial in South Africa as well. This also got not only ethical implication, this has got certain epidemiological implication. For example, when the Johnson & Johnson vaccine was trialed I implemented the clinical trial in South Africa, that's the time South Africa reported a much more virulent subtype of coronavirus. Whereas in the United States, the clinical trial took place when the epidemic was in a plateau. It didn't hit the roof. It hit the curve. So that way, slightly different population groups were at the receiving end of the clinical trial. But remember that United States, there is a very robust mechanism to ensure the best interest for the clinical trial participants. That's not the case in many other countries. I had the opportunity to talk to some of the volunteers in India who participated in the clinical trials of COVID vaccine. One of the issues about the possibility of compensation if anything goes wrong. The Indian context, that particular element was very weak. And the best interest for the clinical trial participants, particularly the compensation for clinical trial participants for the side effects or unanticipated consequences of clinical trial. So this has got specific implication. The third issue of when you look at ethics of clinical trial participants, the first cohort was looked at a particular age group. And it seems the elderly population was left out of the clinical trial participation. Younger children were left out of the population. This may be an illogical issue, but the first batch, they didn't look at the full cohort of the population group for clinical trial. I would say that this also had an ethical implication. When the clinical trial was initiated, the exclusion criteria should have been age. Maybe they should have excluded maybe pregnant mothers on a special case, and maybe a serious debilitating condition could have been excluded, but age should not have been used as a criteria for exclusion criteria. So from that point of view, I would challenge the ethics of clinical trials which lead towards data and evidence which we are utilizing and benefited from the clinical trial. But it may be an operational level, they may dismiss it, but there is an ethical element involved in even the way the clinical trial was being implemented itself. This, I would say that if India is doing a clinical trial, we should look into this aspect of the inclusion and exclusion criteria should be much more inclusive. And this is my take on it.
Okay. I think it's interesting. Yes, Dr. Pandav.
I just want to take one step back and answer the earlier question that you raised about our Prime Minister Narendra Modi's decision. I fully support his decision for three reasons. Number one, as I mentioned earlier, our ancient cultural heritages Vasudhaiva Kutumbakam. For us, the world is a family. In any case, these are very artificial boundaries between the countries. And coronavirus has shown that these are very artificial boundaries. So that's number one. Number two, I would like to remind all of you what Swami Vivekananda said, that he said in the 21st century, India is going to be a global leader, Vishwaguru. This is a classical example where India has become a Vishwaguru. And number three, 200,000 doses as far as India is concerned is a small number. I define epidemiologist as a person who's always in search of denominator. So if you take the denominator of 200,000 and the eligible persons about the age of 45 years for vaccine, this is a minuscule figure. So that's what I have to say on this particular statement. So I fully support our Honorable Prime Minister Narendra Modi's gesture of giving 200 doses of vaccine to peacekeeping force. Thank you.
Right.
Thank
Very
you.
true. I think his action and his initiative has been acclaimed by starting from United Nations Secretary General to the many common people who are expressing their opinion on a social media. And I think among all those who are here, I think there is no doubt that there was a master stroke in health diplomacy by our Prime Minister Narendra Modi. My last question, Dr. Thomas, and it is ethics plus politics. We heard 2 days back that China has not divulged all the information which is needed. Now, I, as a non-medical person, doesn't know anything about medicines, health, and vaccines. I feel that unless we have the roots of this pandemic clear, I think all other things are peripheral. Vaccine is a peripheral. Prioritization is peripheral. We don't know where it has come from. So that means we will be in this situation one after another all the time. And I'm sure if I understand it, China also must be understanding it. So why they should be withholding the data and not allowing it to investigate anything they want? Because that will be beneficial to China also.
Thank you for raising that issue. And yeah, as you know, that WHO conducting a study on the origin of COVID virus, and it went on for almost 1 month. They were in Beijing, they were in China, they in Wuhan. They looked around looking for the specimen and also analysis at the field level. And the report came out on March 30th. But in one way, that report didn't give a comprehensive picture about the source of the virus. They excluded few things. Number one, this never came out of a lab, because that's one of the popular perception that probably it must have escaped from an artificially created it must have escaped from the lab. That they excluded. And the second, they confirmed that this is a species jump. It is from it's just jumped into human population, and then the human population started transmitting. So these are the only two confirmed inference from a almost 250-page report. So this is the interesting part of it. Probably if you look at positive way, this is the beginning of a long inquiry about what is the route of transmission, what is the source of infection. So we reached the first step to eliminate many of some of them in the hypothetical scenarios. We have some very concrete scientific evidence about the origin of the virus. So that way, even though many of the people, even the scientists who are part of the study, they were not very happy with the complete outcome. But we can look at positively. It's a first step towards it. And also there are apprehensions about the actual source of this virus, because it could be related with many other policy issues. For example, it could be linked with maybe environmental disaster. And we are the shrinking environmental habitat must have pushed some of the species out of the environmental habitat, and they have to interact much more heavily with human beings. And second is about the culture of wet market. Because if you're processing meat, particularly wild meat, there should be much more quality assurance. Quality control is needed. For example, today we buy chicken from the local chicken stall. But what's happening is that the assurance of the minimum quality assurance and quality hygiene issues are not taken into consideration. So the entire practice of wet market, maybe that's the one thing, probably we have to look at the greater control, greater hygiene issue, certain minimum standards of hygiene for the wet market, not only in China. Maybe this is one of the lessons we should learn. A country like India, how do we effectively ensure the hygiene condition in the wet market, like chicken and other meat products we are selling and buying in the open market? So this is one of the lessons we should learn from this. The report came out of WHO.
Yes, I will give the floor to Dr. Pandav and then to Ashok Methil. Yes.
Well, health is politics. This Rod Roger said that almost 200 years back. So it's very clear. Health is politics. Number two, our China are not disclosing information. I learned very early in my life that everything else is about something else. That's the answer to your question, sir. Everything else is about something else. Thank
Okay.
you.
Well said. Ashok Methil, Otherwise, I will request Dr. Thomas to conclude. Ashok ji,
You have to unmute, Dr. Ashok.
you have to unmute. Yep. Oh, he's not there.
No, he's online. I can see he's online.
He's online. Yeah.
Okay.
Okay. So I would say that I think it is such an important issue for a social dialogue, the ethics and politics of vaccine, that I think we have benefited a lot from Dr. Thomas as well as Dr. Pandav. And I think we will probably continue, and on this subject probably will keep on coming through the various ways into our future topics. And probably there will be some development as well. Because when now the WHO Director General is talking about that there is a consensus that we should have an international protocol on pandemics. We just shouldn't go in a very random way that first comes epidemic, country reports it, maybe it is reported late, then at one point of time we declare it as a pandemic, then we start about vaccine access, then COVAX facet. I mean, this seems to be going on as if we are not facing a planetary crisis at all. And I think the poor people are suffering. And I think we should not let that happen. And that's why this protocol probably will be needed. So it is another matter how many of them will ratify this protocol. But I will give it to Dr. Thomas to conclude. Thank you.
Thank you. Thank you for
Dr.
this
Pandav,
opportunity.
you have to say something
Please go ahead.
before he concludes. Dr. Pandav?
Yes, I think you have been very polite, sir. You have been extremely polite by using the word random. Random is a number which is scientific. It's a known probability and equal probability. The actual word was ad hoc and arbitrary. You have been very polite by using the word random. Thank you so much. It's ad hoc and arbitrary. Thank you.
Okay. Yes, Dr. Thomas.
Thank you for putting that issues on the spot. And we are also using, maybe the next discussion should be about the language of the COVID pandemic. We quite often, we are very diplomatically beat around the bush, not addressing some of the real issues. So from that context, let me make few concluding remarks. We should look at COVID response by the state governments, institutions, foundations, UN agencies based on the framework or the lens of human rights, from the lens of equity, from the lens of justice, and particularly health equity. Any actions, is it contributing towards health equity or health inequity? This should be one of the fundamental criteria for evaluating all our efforts. And also, I acknowledge that the COVID response has got local dimension, regional dimension, national dimension, international dimension. And the slogan we have from the Sustainable Development Goal is leaving no one behind. Because if one person is with infection, everybody is at the risk of infection. That principle is and could be approached only from the framework, from the lens of health equity. And probably this is some of the new insight about public health. Public health, quite often we thought, we'll have vaccine and we are taking care of the pandemic. But the vaccine itself is not going to contribute to the complete elimination of the vaccine and the virus. And probably the lesson we are learning by applying the ethics and equity principle is that we need to learn how to live with the virus. And by applying the principles of equity and justice and fairness. So that way, this question also begs to another question. If we can control the COVID pandemic, why we can't control other infections like diabetes, cardiovascular disease, TB, leprosy, HIV infection? So we have the capacity and logistical capacity to distribute vaccine on a national level. Then why not? And we eliminated the polio vaccination contributed to the elimination of polio. So we should have a comprehensive vaccination program. And that basket is, we're talking about almost 20 plus vaccines. Maybe this vaccine initiative, the COVID vaccine initiative should be expanded. The scope should be expanded. The logistical system should be in place, should be utilized for utilizing to vaccination of all other available vaccines as well. And also our trade agreements, which is hampering our capacity to manufacture, should be immediately relooked. This will be my request to all the political leaders. We have to immediately look at the possibility of issuing compulsory licensing for manufacturing COVID related vaccines and the diagnostic equipments. Thank you very much, and I look forward to continuing such important dialogue. And let me thank Dr. Rajan Shinde and Dr. Chandrakant Pandav, because it gave me an opportunity to organize my thinking about this important issue. And let me thank MIT World Peace University and the School of Public Health for allowing me to utilize my time for being part of this dialogue. And also let me thank Therese Center for facilitating this dialogue. And thank you for all the participants. Thank you very much and have a good day. Bye-bye.
Thank you. Thank you, Joe. And thanks for your time. Thanks, Dr. Pandav, for your time. You asked extremely relevant questions, and that made this particular dialogue lively. So we meet next Friday again for the Friday talk. See you, all of you. Bye.